Hello and welcome to Healthy Living. I'm Dr. Donald Pelto, and today I have the privilege of talking to Dr. John Guiliana, and he is the Executive Vice President of Nemo Health. And I've always admired John for his communication skills. He's lectured tremendously about the topic. Those that are watching, you've probably seen him lecture before on this specific topic, but we haven't heard him lately. So John, welcome to the show.
Thank you, Don. It's great to be here.
So John, we're going to dive right into it. And what is your best communication tip for doctors?
Well, if you're asking me for the best one, I'm going to build up to that, Don. How does that sound? Because
okay.
I think we first need to really talk about why communication is so important. And it's really the art involved in the art and science of medicine. Patients will ultimately do what we think is best for them if we can convey that message in a very confident, very articulate manner. And in fact, they don't do what we ask them to do, what we know it's best for them, if we don't convey it in that manner. And that leads to a whole host of complications that physicians often see associated with noncompliance and non-adherence. So to build up to this important question as to what's my best tip, I think first we have to understand that in order to be a good communicator, you really first have to be a good listener. You have to really start by understanding the difference between active and passive listening.
Okay.
And when you actively listen to somebody, you are listening for true understanding so that you can reflect that understanding back to them in the form of a paraphrase that really captures their emotions. And it's the first building block of this bridge of trust and credibility that we're trying to build. Because when they hear that you understand them, everything else becomes much easier. Everything else we're going to talk about becomes much easier. So that's the first thing, is really becoming a good, active listener. Then, it builds upon that. We've got to understand that communication has three components. It's not one singular component. We have a verbal, a vocal, and a visual component. And while many of us focus on the verbal component, the words that we speak, we sometimes forget that 2/3 of communication is actually nonverbal. It's the vocal and the visual. The vocal is the sound of your voice and the inflections and the tone. And the visual is what the person is actually seeing, your facial expressions, your hand gestures, your body posture. All of those things are 2/3 of actual communication. But then let's talk about the verbal, because that's going to address your question directly as to the best tip that I often give physicians. First, understanding the fact that your body language and facial expressions all have to be, in the perfect manner in order for that patient to really find you trustworthy and credible.
Yeah.
But then the verbal, my best tip is this: take the most common dialogues that you have in your practice, be they clinical or administrative. So this works for both your front office staff, your billing department, and write out a script to the answers to those most common questions. When you write out a script, you can be very sure to be using the best possible words, free of semantics. You can rehearse them, make sure that it's clearly understandable by asking other people if they understand the message you're trying to convey. And once you practice it enough, trust me, it becomes almost as if it's unrehearsed. It's not going to sound like it's scripted, but it gives you the opportunity to really focus on some of the things that maybe we'll talk about after we get through this part of it, which is, that's the best tip, is write out scripts for your most common dialogues. What caused my heel spur? Where did I get this bunion from? Why do I have to pay this copay every time I come into the office? Script them out.
That's awesome. I want to go back because what you said was something very important, John. You talked about rephrasing, or I think you used a different word. When we sit, I'm assuming you probably notice this if you shadow doctors in their treatment room with patients, that we listen to them. We actually know the problem before they even start speaking. And is it important for us to still listen to them talking about their fungal toenail or their ingrown toenail or their plantar fasciitis? Is that necessary to do that reflective listening?
That's a great question, Don. The answer, of course, is yes. You know, you're absolutely right on when you say that the vast majority of diagnoses we have immediately because they're simple, straightforward. But if the patient doesn't feel heard, and if you can't capture, by allowing them to speak, if you can't capture the emotional component behind the message they're trying to convey to you, that gives you the inability to reflect back a paraphrase to them. Like, Don, this heel pain sounds like it's extremely frustrating and concerning to you. You can't even play the golf game that you used to once play. We need to do something about that. That simple paraphrase is going to set you up for success.
Perfect. Thank you for clarifying that. That power phrase or paraphrasing, I think, is excellent. Great. And then also the other tip was scripting out, writing out how you treat things. Perfect. And what's the, now I'm going to go in my order and then we can deviate if we'd like. The most common mistake might be one of those other things that we just talked about. Is that one of the most common mistakes that you hear with communication?
It is, but it's probably not the most impactful mistake. We see, look, we're all imperfect human beings. So, when I have the opportunity to be coaching doctors and watching them, I realize that, hey, I make some of these mistakes myself. There's, unless you can hit 18 holes in one, there's always room to improve your golf game. So I think the most impactful mistake is, and we'll talk about these laws as you write out scripts, the most impactful mistake is not using the law of decisiveness in your language. And there's 3 laws that I always talk about that physicians have to follow in order for them to build this bridge of trust and credibility. And that's the law of decisiveness, the law of association, and the law of contrast. The single most prevalent mistake I see is lacking in the law of decisiveness, where doctors will say things like, maybe we need an orthotic, or perhaps we should send you for some blood work. Very subliminally, that maybe and perhaps that you've used breaks down the trustworthiness of the message. If you know they need an orthotic, or you know they need blood work, or you know they need an MRI, you should be stating that emphatically by using the power words such as, it's important that we send you right now for an MRI, or it's critical, it's essential, it's vital, it's important, not maybe or perhaps.
Now, why aren't doctors using those power words? Is it because they're not trained, or they do it, they're shadowing someone else they learn from, their residency director?
It's a good question. I'm not sure I have the definitive answer to that. I can only give you a hunch that I just think it's a habit. I think it's a habit in our everyday lives.
Now, let's go on. Let's talk about something that we might say that is, oh, you might do well with orthotics. As we are physicians, they might do well, they might not do well. We don't know. How can then we be decisive in saying that these are important or these are necessary? Just to help clarify that for those that are listening. They might be saying the same thing. Well, you might do well with amnio and it might not work. How can we still be decisive if we're uncertain? We shouldn't pass that on to them?
Yes. Another great point, Don. So the answer to that is, of course, yes. Our message also has to convey the fact that this might or might not work. So if I would say something like this, and I'll let you be the interpreter here, if I would say something like this to you, it's important that we get you into a pair of functional foot orthotics. They work much like eyeglasses do to control the mechanical instability of our eyes by controlling the instability in our feet. they'll hopefully preclude the need for further, more aggressive things like surgery. They'll hopefully preclude the need.
That's where
So
you
there's,
put the insecurity or the.
yeah, there's always a message that, and patients will sometimes ask, well, you guarantee these? Well, of course not. I mean, that's the science of medicine. We're talking now about the art of the art of medicine, but the science of medicine is fallible, and our message has to convey that.
I think that's great. So that's the decisiveness. Let's go on to the association. I think you gave that kind of in your example, but if you could elaborate more.
Sure. Many of the things that physicians do, be it a podiatrist or other specialists, are unfamiliar to the common layperson. So we always have to make sure we're speaking first in layperson's terms, but help them understand what you're trying to convey by using the law of association. We talked about the law of decisiveness. Now the law of association, and you did hear that just now, where I said that the functional foot orthotics work much like prescription eyeglasses to help control the mechanical instability of our eyes. These help control the mechanical instability of our feet. That's the aha moment that the patient gets. Now I get it. Now I understand it.
That's awesome. And then contrast. How does that contrast?
Contrast is telling patients, and by the way, sometimes you can't use all three of these laws. For example, it works well with orthotics, but the law of association might not work well, with a bunion surgery and an explanation of a bunion surgery. But the decisiveness most definitely can, and often the contrast can. So the contrast is important because sometimes we need to tell patients not only why they should do something, but what could possibly happen if they don't. So the law of contrast you heard in the orthotic dialogue, that it hopefully will preclude the need for future surgery. That tells the patient, well, future surgery could happen if I don't go into orthotics. But for things like diabetic shoes, it's vital that we get you into extra depth therapeutic shoes designed for diabetics that will hopefully preclude all of the bad complications that you've heard of, like amputations associated with diabetes. That's the law of contrast.
Wonderful. Now, just out of curiosity, these techniques, are these inventions of John Guiliana? Are these books that you've read? Were you always a good communicator, or was it something that you learned?
Really a combination of all three, Don. So I'm ancient at this point, so I've been around the block many times. I practiced for many years, and early in my career, in fact, in my residency director was a skillful gentleman about communication, and I hung out with him a lot. He really inspired my interest to further pursue this. So yes, I've read a lot of books, I've attended some seminars, but most of these things, and this is why I believe they call it practicing medicine, most of these things I did, by just practicing. What works, what doesn't work, cross that off, circle this, that works. It's just all a matter of practice.
Yeah, the young doctors, we have one starting here with us, and I say you should always go around shadowing doctors and bringing your notepad. And you'll get those gems, because all of us have ways of explaining things, and it's taken us many, many trial and error times to learn those.
Absolutely. And what works for me might not work for you. You're going to change the language, but the foundation is always the same. You've got to convey it clearly, concisely, in a confident manner. And you've got to build this bridge of trustworthiness and credibility and this likability factor. Likability is so important, and that's where your facial expressions, your smile, your touching patients or shaking hands, perhaps after we get through the pandemic. But all of those things are so important for likability, because likability, patients, two things I've always professed. When a patient likes you, they're going to generally do what you recommend them to do, what you know to be best for them. Mm-hmm. And number two, when a patient likes you, they generally don't sue you if things go wrong. I know it's a generalization, but most patients do not sue physicians they like.
That's great point. Great point. Let's go on and talk about when you finish. Let's say you're talking about plantar fasciitis and you are going through, there are a lot of different treatment options for plantar fasciitis. And many times we'll go through those options and cause a little bit of confusion in the mind of the patients. Everyone who's listening knows you can do physical therapy, you can do stretching, you can do foam rolling, you can buy something on Amazon, you can do cortisone, you can do amnio, you can do orthotics. There's a lot of things. When presenting these, what's a good way of not overwhelming patients and saying, well, do you share everything and then say, well, what do you think, and let them choose? Or do you say, this is phase 1, phase 2? What do you think works best?
Great question. So, we back in the very early days of medicine, there was an activity passivity model that was always used right up until, I believe, the 1960s. And if you go back and you watch episodes of Marcus Welby or Dr. Kildare, you're going to see the classic activity passivity model where the doctor was God and the patient did nothing but listen and did exactly what that doctor said. Well, we've now evolved way past the model of activity passivity. We are now in a model that is best suited for our community, for our consumers, of mutual cooperation. Mm-hmm. And mutual cooperation is going to almost mandate that we be educators. As physicians, we have to be educators. So to answer your question directly, Don, and this can vary amongst physicians, but this was my philosophy, is I talked about where did it come from? Whatever we're talking about, the bunion or the heel spur, where did it come from? What do we need to do about it? And how do we go about doing that? So I would talk about where this came from. Then I would get into, here are some manners in which this entity is treated. Mm-hmm. But in my experience, for you particularly, because of a number of things that you present with, I'm going to recommend this method. So the patient is educated as to, yeah, there's physical therapy for it. Yeah, there's wider shoes. But in my experience, because of your unique presentation, it's important that we do the following. So now they're educated. Nobody could ever say, well, Dr. Guiliana never told me that I could just have physical therapy for this. Or Dr. Guiliana never told me that an orthotic may fix my problem. We talked about it, and you have to be a good educator.
I think that's key. If anyone's watching this, I think right there is the key to everything is, I like it because you're generalizing and then you're saying, well, in my experience, because that's why they come to us. They could go to Amazon if they want to know all the treatments for plantar fasciitis. Yeah. They're coming to see us, and you could say, well, in my experience, you may have 10, 15, 20 years of experience. Your unique situation, we're going to recommend this. First visit, second visit, we'll change it. It can't be a boiler cutter.
And Don, I want to reference something that you said, or it was part of the question. Do you give this menu and let the patient just choose? And the answer to that really is why we're talking about being an influential communicator, right? If you did everything right in your presentation, you are literally going to have that patient convinced that your recommendation is the best. So you're not going to give them this menu and say, sit back, take your time, and choose. Circle the one that you want. We know that that's bad medicine, right? You have to know in your heart and in your beliefs what would be best for this unique patient, but then communicate it in a way that drives them right down that decision-making path.
That's great. Let's talk about making improvements in the way we communicate. And that may be twofold. One fold is, well, how can I start integrating this if I want to make improvements? And second, what happens if they say no? And a lot of people, I think they give people options to choose because they don't want to get any rejection and people saying, no, I can't afford it. I'm not willing to. Do we ever, I know some doctors, well, I'm sorry, you have to see someone else because I don't do that. What are your
Yeah.
thoughts?
So I guess that really depends upon what we're talking about, Don, right? So let me give two extreme examples. The patient with heel pain can't afford an orthotic.
Okay.
I know what's best for them is a functional prescription custom orthotic, but they can't afford it. They have no insurance for it. We obviously don't want to abandon that patient and just say, well, that's too bad. We have to go down the road of alternatives, right? Be it an over-the-counter orthotic, physical therapy, whatever can accommodate to help heal that patient and make them better. But the other extreme would be something like this. A patient comes in with a severe bunion, with a severe intermetatarsal angle, and that patient decides on their own, I don't want to be non-weight bearing, I don't want to be put into a cast, I want a simple bump and run. That's not happening.
You can't let them dictate treatment.
Right.
Perfect. Great. And in terms of improving, let's say someone's just starting out, finishing residency, or they've been in practice, but they've never really practiced communication and they're a little scared about doing this. Any good tips for making improvements in their communication? Any evaluation system, self-improvement?
Yeah, what I did very early on, especially when I was building my practice, taking in associates and partners, we would religiously work on our scripts, talk about our experience with the scripts, tweak and edit them. But the most important tip associated with this is you never really know how you sound or look until somebody videotapes you, until somebody just takes out their cell phone. And what I recommend you do is, as a team, including the assistants, is do these mock presentations in your treatment room. And again, involve the assistants as well, because they should be intimately tied to your clinical protocols, discussing, how to wear a night splint or what a night splint is all about. Practice these in mock episodes where you're filming them and you could go back and watch them, watch your body language, your facial expressions, your tone, the pace of your speech, all of those important things. So that's how you improve.
That's great. That's great. Any thoughts behind doing, you're familiar with this, I'm sure, A/B split testing, maybe present it one way one day and then the other way and see which one works better in terms of presenting? Have you ever considered that?
Sure. And I think intuitively we do that. I think intuitively, in a very informal manner, we do that as we're watching the feedback and gathering feedback from watching these tapes.
That's great. And then the final question before you, if you want to share any other tips that you might have, is the actual aspect of being a confident communicator. I know that comes with, 20, 30 years of experience like you have. I think time gives confidence. Are there any other techniques for increasing the confidence that we can have as a doctor? Not being arrogant, but being confident in communicating.
Right. You don't want to cross that line of being arrogant, but you do want to sound confident. You have to have a confident tone. And some of these things are very coachable, Don. I think that if you find yourself, and this is the feedback that you can get from your loved ones and as you're practicing the scripts, if you find yourself lacking confidence, sometimes that comes from deep within. And if your tone is not confident, patients will absolutely sense that. And that's sometimes I have recommended people actually go to seminars and conferences to help build their level of confidence. You come out of school knowing everything that you need to know. You come out of your residency, hopefully very well trained. There's no reason why you shouldn't be confident, but some of us have a very deep-seated, introverted mechanism behind that. Mm-hmm. And it's a matter of just getting rid of that by maybe attending some seminars.
Perfect. Well, great, John. I think we covered a lot in this time. I really appreciate your tips, and I think they're going to be valuable for anyone listening.
I'm happy. Thank you, Don, for having me.
Okay, and I'm going to put some information underneath this video about your company, Nemo Health, and if anyone wants to learn more, they can go to that website.
Very good.
Okay, thank you.
Thank you.
Hey guys, thank you for watching Healthy Living. You're going to find a few links here I'd like you to click. One is to subscribe to this channel on YouTube. Also, you can learn more. There are some videos here you can see.